So today we will be talking about the extraocular muscles, particularly its actions at the bedside. First, we will cover the essential anatomy. First, we should know the anatomy of the orbit. There are two orbits. They have got medial walls which run parallel to one another. This is parallel to the other one. And you have got a lateral wall which is about 45 degrees to the medial wall, or about 90 degrees to each other. So something like a cone. Cone apex is posterior. Anteriorly it is open with the eyeball inside. So parallel medial wall, oblique slanting lateral wall, one making 90 degrees with the other lateral wall. The eye will be sitting in the bony orbit. It will have floor, medial wall, lateral wall, and a roof. It is something like a pyramid in shape. Now you have got muscles that start from the apex of the orbit in and around the ligament of Zinn, tendinous ligament of Zinn, ZINN. You have got a superior rectus, you have got a medial rectus, you have got inferior rectus, you have got superior oblique. The inferior oblique does not start from the ligament of Zinn. So you have got these muscles, all except the inferior oblique, will be arising from ligament of Zinn or very near to that. The recti will be superior rectus and the inferior rectus. The oblique will be superior oblique and inferior oblique. The same thing, superior rectus, inferior rectus, superior oblique, inferior oblique, medial rectus, lateral rectus. Now, what is the nerve supply? I am not dwelling upon the nerve supply and the other things, mainly concentrating only on the actions, which usually is difficult for the BD students. All are supplied by oculomotor nerve, except the lateral rectus and the superior oblique. All of us know that lateral rectus is supplied by abducens nerve. The superior oblique will be supplied by the trochlear nerve or fourth nerve. All of us know this mnemonic SO4, superior oblique, lateral rectus 6, sixth nerve, and rest of the muscles are supplied by third nerve. So that will be third nerve will be supplying superior rectus, inferior rectus, medial rectus, and inferior oblique. So this formula will be useful. Everybody knows about it. LR6, SO4. Now third nerve has got a superior division and an inferior division. The superior division will supply the levator palpebrae superioris, the superior rectus, and then come the medial rectus. Then the inferior branch will supply the inferior rectus. Then you have got the ciliary ganglion and the inferior oblique muscle terminally. This is the usual pattern of the nerve branching out. Now all of us know that it is arising from the ligament of Zinn. Ligament of Zinn is placed in the posterior aspect of the orbit, that is at its apex, in relation to the superior orbital fissure. This is the superior orbital fissure. Can you see the cursor, Dr. Kishan Rao? Superior orbital fissure, which is divided into three compartments: superior compartment, middle compartment, and the inferior compartment. Below that, you have the inferior orbital fissure. There is the usual question: structures passing through superior orbital fissure. There is a mnemonic for the structures passing through. The superior portion, that is the upper portion, the nerves that are going through that or passing through will be summarized by LFT, lacrimal, frontal, trochlear. Then you have got only third and sixth nerve. Third, you have got two divisions. That is placed in the middle compartment. Then the sixth nerve also is here. Then also nasociliar nerve is in the middle compartment. Superior ophthalmic vein will be placed in the superior compartment, and inferior ophthalmic vein will be partly in the inferior compartment, also in the inferior orbital fissure. To summarize, it was a usual question, so you should know. LFT, lacrimal nerve, frontal nerve, trochlear nerve with superior ophthalmic vein in the upper compartment, superior compartment. Middle compartment surrounded by the ligament of Zinn will carry third nerve, two divisions, nasociliar nerve and sixth nerve. Superior ophthalmic vein and inferior ophthalmic vein, two branches will be distributed in the lower compartment of the superior orbital fissure and the inferior orbital fissure. This is in general the arrangement. Now the superior rectus, origins of the muscle, superior rectus arises from the superior part of the common tendinous ring, that is ligament of Zinn. Inferior rectus, obviously from the inferior part of the common tendinous ring. Medial rectus from the medial part of the tendinous ring. Lateral rectus from the lateral part. Superior oblique has got two origins. One is the body of the sphenoid, superior and medial to the optic canal, and sometimes it arises from the ligament of Zinn. So it is always all the superior oblique and other recti muscles which I have mentioned so far will be arising from the apex oblique, that is ligament of Zinn or around. Inferior oblique muscle has got a separate course. It doesn't start from the ligament of Zinn. It starts from the anterior part of the floor of the orbit. Anterior part of the floor of the orbit. You got this one from the anterior part near the lacrimal bone. It runs backward and get inserted into the posterior, inferior, outer quadrant. We will come to insertions later because it is bearing with the actions which we are going to learn. So today we'll be discussing mainly actions, how to remember at the bedside and for examination purposes. So this is the orbit. This is the medial part, this is the lateral part, this is the lateral rectus, this is the medial rectus, and the superior oblique is coming and going after going through the trochlea. Runs posteriorly above the globe, getting inserted into the posterior superior outer quadrant. That is very important to remember. Where is it inserted? It is superior oblique is inserted into the posterior superior outer quadrant after turning through the trochlea. So originally starts from the apex of the orbit, runs along the roof, turns backward through the trochlea and runs above the globe, runs posteriorly above the globe to get inserted into the posterior superior outer quadrant. That you should remember. So this is the course of the superior oblique. So functional origin. Real origin is somewhere here anatomical. Functional origin will be at this point. This is the trochlea from where it turns a turn backward. So it appears to act from this point. So therefore, the actions will be the posterior part of the globe will be pulled to that side. That is the importance of looking for it. Now, axis of the globe and axis of the orbit are not the same. They make an angle. What is meant by axis of the globe? It is the anterior posterior axis or the visual axis. If you just put a straight line from the macula along the center part of the cornea, that forms the axis of the eyeball. On the other hand, the orbit, the axis of the orbit will be slanting, making an angle with the axis of the eyeball. How much it is, we will come to later. So what we should remember is axis of the eyeball and axis of the orbit are not the same and they are not parallel. They make an angle. Now let us look at the angle with which the muscles make with the visual axis. We already talked that the superior rectus will arise from the apex of the orbit, that is in the ligament of Zinn, the area of ligament of Zinn, upper part. It runs above the globe. So globe is there, it runs above. It is, suppose it is by right-sided globe, it starts from here, goes above it, and getting inserted into the anterior superior outer quadrant. This is again important for remembering the action. Where is it inserted? It is inserted to the anterior superior outer quadrant. Because it is superior rectus, it is going above the globe. Where is it inserted? It is anterior part. Is it outer part or inner part? All muscles are inserted only into the outer quadrants. It may be anterior for the rectus, posterior for the oblique. We will come to that. Therefore, summarizing, superior rectus starts from the apex of the orbit from the ligament of Zinn, runs above the globe and runs outward to get inserted into the outer superior anterior quadrant. So when it pulls, it will pull it upward and then medially. That will explain why superior rectus is an elevator. The anterior part is elevated. It is attached on the outer quadrant. So when the muscle contracts, the outer quadrant will be moved medially. That will explain the adduction. And outer quadrant, that is outside the 12 o'clock meridian, will be pulled towards the origin. Therefore, it will produce an intorsion. Therefore, superior rectus will be an elevator. It will be an adductor. It will be an intortor. Why is it so? It is getting inserted at the anterior superior outer quadrant. Therefore, when it contracts, anterior superior outer part will be turned medially, will be turned upward, and will be rotated towards the nose. The 12 o'clock meridian will be moved towards the nose. Therefore, superior rectus will be described. We will come to that again in detail. Superior rectus will be elevator, it is an adductor, and it's an intortor. Now come to the inferior rectus. It is starting from the inferior part of the ligament of Zinn. It runs parallel to the superior rectus. Only thing is, superior rectus is running above. This is running below. And where will it get inserted? It will get inserted into the anterior inferior outer quadrant. Whereas the superior rectus was inserted into the anterior superior outer quadrant, whereas inferior rectus naturally will be inserted into the anterior inferior outer quadrant. So when it contracts, what will happen? The anterior inferior outer quadrant will be drawn towards the origin. Therefore, it will produce an adduction and the lower portion will be pulled downward. Therefore, it will produce a depression. and also it is attached to the outer anterior inferior quadrant. So that part will be moved more medially. That means 6 o'clock meridian will undergo an invert rotation towards the nose, which means the 12 o'clock meridian will go outward. Therefore, inferior rectus will be an extorter. Summarizing, inferior rectus will be a depressor, it will be an adductor, and it will be an extorter. Whereas superior rectus was an elevator, was an intorter, was an adductor. Now looking at the oblique muscles, we have got two oblique muscles, superior oblique and inferior oblique. Superior oblique, as I already told you, arises from the most posterior part, that is the apex of the orbit, runs along the roof, then turns backward. Again, run, because it is superior oblique, it is running posteriorly and outward. To get, comes like this and runs posteriorly and outward to get inserted into the posterior superior outer quadrant. Again, it is an outer quadrant. It is in the posterior part. It is the superior part. So the insertion is at the posterior superior outer quadrant. Now, superior oblique, very often we learn that it is a depressor. A muscle that is working above the globe, how does it become a depressor? That is because globe is round in shape, the posterior part is elevated, posterior superior quadrant is elevated. Therefore, what will happen to the anterior portion, that is the cornea, it will get depressed. Actually, superior oblique and superior rectus, both of them are elevating. Superior rectus is elevating the anterior part, superior oblique is elevating the posterior part. Therefore, the superior oblique becomes a depressor. So when a part of the globe, posterior part is elevated, means anterior part should have to come down. Therefore, superior oblique is a depressor, and it will move the posterior outer quadrant more medially towards the midline. So when the posterior part is getting adducted, the anterior part will get abducted. Therefore, superior oblique will be a depressor, it will be an abductor. Now it is attached to outer superior quadrant. So when it contracts, it will bring the outer posterior superior quadrant in a rotatory manner towards the nose. Therefore, it will act as an intorter. Now come to the inferior oblique. Inferior oblique course is almost parallel to the superior oblique after it has crossed or gone through the trochlea. Almost parallel. And start from the anterior part of the floor of the orbit near the lacrimal bone, and it is getting inserted into the posterior inferior outer quadrant. Which quadrant? Posterior inferior outer quadrant. So when it pulls the posterior quadrant downward, the anterior portion, that is the cornea, will go up. Therefore, inferior oblique will be an elevator. Now, it turns the inferior posterior outer quadrant more medially. That means the anterior cornea will move laterally. So it will act as a lateral rotator or abductor. So there is an element of abduction apart from elevation action. Next will be the inferior portion, inferior posterior outer quadrant. It will be drawn towards the midline. That means the 6 o'clock meridian will be intorted. When you say intorted, moving towards the nose. When the 6 o'clock meridian is moving towards the nose, 12 o'clock meridian will move outward. Outward. Therefore, inferior oblique will be an elevator. It will be an abductor, also, and an extorter. So this is a summary of the actions of the extraocular muscles. Their origin is important. Their insertion is also very important. Therefore, if you know this origin, insertion, where is it inserted, you can predict the actions of these muscles. Now, elevation means looking upward. Depression means looking downward. Adduction means eye moves towards the midline. Abduction means eye moves away from the nose or midline. What is intorsion for eyeball? That we should know. It is a globe, rounded structure like a clock. Anterior portion is like a clock. So if the 12 o'clock meridian is moving towards the nose or the midline, 6 o'clock will move outward. So standard teaching is intorsion means what is the movement of the 12 o'clock meridian? Is it moving towards the nose or away from the nose? Intorsion is defined as by the movement of the 12 o'clock meridian. So if the 12 o'clock meridian goes like this, it is towards the nose, so it is intorsion. 12 o'clock meridian goes like this, it is extorsion. So when this is getting extorted, this will get inserted, then 6 o'clock. We don't bother about 6 o'clock. By standard definition of intorsion is 12 o'clock meridian moving inward. All of you know that cornea is transparent. You cannot have identified 12 o'clock and all that. Therefore, when it is getting intorted or extorted, it will be difficult to identify it. So what is suggested at this point is to look at a vessel near the 12 o'clock meridian. See what happens to that vessel. Vessel you will be able to see in the sclera near the 12 o'clock meridian. Imagine what will happen if this vessel goes in this direction, it is intorsion. If this vessel goes outward like this, it is extorsion. That is how we define in the cornea, which is totally transparent. You cannot identify the movement. So look at the vessel nearby. Imagine what would have happened to the 12 o'clock meridian. Either goes towards the midline, towards the nose, or away from the midline. Depending upon that, you can decide whether it is an intorsion or extorsion. Again, intorsion, 12 o'clock meridian moves, rotate towards the node. Extorsion, 12 o'clock meridian away from it. So summarizing the action, this is a very popular diagram given in one rounded structure. It is easy to remember. Now, this is the lateral rectus. That means it will be outside the medial rectus. So nose should be here. So it should be a left eyeball. Now, what is the action of superior rectus? Now, there are 3 arrows. Students can learn like this. One arrow is upward. We are already saying that superior rectus is elevator. And it is moving toward the nose. Nose is here. So it is a adductor. And nose is here. 12 o'clock meridian is moving like this. So this is arrow. One arrow depicts elevation. Other arrow depicts adduction. This arrow depicts intorsion. So you got 3 arrows from one point, one above, one is adducting, other is intorsion. Now that is the action of superior rectus. Now look at the inferior rectus. We already seen that it is a depressor. Because it is attached to lower portion, anterior, inferior outer quadrant, it will depress. And it is in the outside quadrant, so it will cause intorsion. Adduction. So superior rectus will adduct, inferior rectus also will adduct. Now it is turning the 6 o'clock meridian towards the nose. That means the 12 o'clock meridian will go away from the nose. This will be the nose. So it produces an extorsion. For easy remembering, student can remember that this arrow, that is the torsional activity of the superior rectus, and the torsional activity of the inferior rectus, they will be meeting each other. So elevation, adduction, intorsion. This arrow will meet this arrow. So superior rectus torsional and inferior rectus torsional movements, the arrows will meet each other. That is an easy way of remembering. Now come to the superior oblique. We already seen one rectus that is bringing the eyeball downward, inferior rectus. The other depressor is superior oblique. Superior oblique, we already seen that it has got functional origin at the trochlea, even though ligament of Sin somewhere near the real origin, anatomic origin. Functionally, the pull is towards the trochlea. So it pulls the posterior superior outer quadrant upward. Therefore, anterior quadrant is depressed. Now the outer quadrant is pulled towards the midline, toward the nose. Therefore, superior oblique will act as an intortor, and also it will act as an abductor, which I already explained. So you have got a inferior rectus which is producing adduction. Superior oblique will produce abduction. Now come to the inferior oblique. Inferior oblique is the second elevator. Inferior oblique is arising from the anterior part of the floor of the orbit near the lacrimal bone, runs below the globe, getting inserted into the posterior inferior outer quadrant, and it pulls it downward. Therefore, it will elevate the anterior part. Therefore, one action will be elevation, the other action will be abduction, and next action will be extorsion. So summarizing, superior rectus is an elevator, then adductor, intortor. Inferior rectus will be a depressor, it's an adductor, it's an extortor. Superior oblique is a depressor, is an abductor and intortor. Inferior oblique is an elevator, an abductor, and it is an extortor. Again, remember, this arrow and this arrow of the obliques will meet. Similarly, the torsional activities of superior rectus and inferior rectus will be meeting. That is for remembering the diagram. Each vertically acting muscles will have three actions which are already depicted. So this is a text from the textbook. Medial rectus and lateral rectus is no confusion. Medial rectus is an adductor, lateral rectus is an abductor. Superior rectus primary action will be an elevation, but there will be a secondary action which is an intorsion. And already we have said that is an adductor. Inferior rectus will cause depression and extorsion, again adduction. You please note that superior rectus and inferior rectus, both recti are adductors. Superior oblique, even though it's a depressor, primary action is intorsion. Secondary action is depression, and tertiary action only is abduction. That is because of the muscle attachment. The muscles, the mechanical efficiency will work in such a way that primary action will become intorsion for superior oblique, secondary will be depression, tertiary will be abduction. Inferior oblique, primary action will be extorsion, secondary action will be elevation, and it will be a tertiary action will be abduction. Please note that Superior oblique and inferior oblique are abductors. Recti are adductors. The elevators are, to summarize, superior rectus, primary action. The other elevator is inferior oblique. That is secondary action. Depressors, inferior rectus, primarily it is a depressor. Superior oblique is also a depressor as a secondary action. Main action, prime action for superior oblique is torsional activity, that is intorsion. Adductors are mainly medial rectus, all of us know about it. Superior rectus, inferior rectus, both recti are adductors. Main adduction action is done by medial rectus. Abductors, lateral rectus and superior oblique, inferior oblique. So adductors are medial rectus, superior rectus, inferior rectus. Abductors are lateral rectus, superior oblique and inferior oblique. Both obliques will happen to be abductors. Both recti will act as adductors. Intorters, both superior rectus will be an intorter, superior oblique will be also an intorter. Extorter, inferior rectus as well as inferior oblique. Both superiors are intorters. Student can remember like this. Both inferiors are extorters. Both recti are adductors. Both obliques are abductors. Again, when the 12 o'clock meridian intorts, 6 o'clock meridian will extort. We will not bother about 6 o'clock, we will bother only about 12 o'clock meridian. Now regarding the rotation, there are three imaginary axes around which rotation will happen. One is an x-axis, other is a y-axis, then another one is an z-axis. So you have got a horizontal x-axis, anterior posterior y-axis, and a vertical z-axis. Now from the diagram you can imagine that when the muscles are contracting around an x-axis which is horizontal, it will cause elevation and depression. So you can easily remember. So horizontal axis, the muscle pulls, it will go upward and downward. So elevation depression action takes place around an imaginary axis which is horizontal. So horizontal axis is x-axis. This is conventionally accepted like this. Now you have got the y-axis. Y-axis is the anterior posterior axis. Anterior cornea is here. This is the posterior part of the globe. Anterior posterior axis. Anterior posterior axis. So what is the movement you can expect? Anterior posterior axis, it can rotate. So intorsion, extorsion or the torsional activity occurs around the y-axis. Now you have got the vertical axis, z-axis. It is like this. What can happen? Movement can be sideways. That is a horizontal movement. So around the z-axis, you will have an adduction and abduction. So there are three axes, x, y, z. We'll see once more. Three possible axes of rotation. A horizontal axis, that is an x-axis, anteroposterior axis, y-axis, and vertical axis, z-axis. There are three axes of rotation. Again, x-axis, elevation depression happens. Z-axis, horizontal, vertical axis around which horizontal movements occur. Adduction, abduction. Anterior posterior axis where intorsion, extorsion happens. Now, it is difficult to remember this, but as a mnemonic you can use this. You got Z, you got three limbs. I just put it like this. So Z will stand for a vertical axis. Z will stand for vertical axis. You have seen that. Z will, last line, Z will be standing for vertical axis. So Z stands for vertical axis. They've got an X axis. Take the two limbs and put it parallelly and then draw a line. So X axis will be horizontal. Then anteroposterior axis PA. You can remember pay. Y axis. So anteroposterior axis, which is Y axis. Horizontal axis will be X axis. Vertical axis will be Z axis. From that way, you can remember the axis around which rotation happens. Now, this is the muscle from the muscle origin insertion from the superior aspect. This is the lateral aspect. This is the medial part. This is the lateral part. This is the lateral rectus. Looking from above. Again, looking from above, this is the medial rectus. You got the ligament of seen somewhere here. Inferior rectus is going below the globe. So this part is hidden. It starts from this portion, that is the apex of the globe, runs anteriorly below the globe, outward it is going, getting inserted into the anterior inferior outer quadrant. Superior rectus start from ligament of Zinn, getting inserted to the anterior superior outer quadrant. Superior oblique start from the apex of the orbit, turns around the pulley, trochlea, runs above the globe, running posteriorly, getting inserted to the posterior superior outer quadrant. Inferior oblique, it is parallel to the superior oblique. We have seen the previous diagram, superior oblique like this. Inferior oblique is parallel to that. Only thing is it is below the globe, arising from the anterior part of the orbital floor near the lateral bone, running below the globe, getting inserted to the posterior superior inferior quadrant. Posterior inferior outer quadrant. Correct once more. Start from the floor of the orbit near the lacrimal gland, runs posteriorly below the globe, getting inserted into the posterior inferior outer quadrant. Now look at the each muscles. Now superior rectus, origin from the ligament of Zinn, runs anterior and outward, insertion to the anterior superior outer quadrant. This is the globe, anterior superior outer quadrant. It is somewhere here. When it pulls, it will go upward. So it's an elevator. And it is in the outer quadrant, so it will turn it medially. So it's an adductor. And it is outside the 12 o'clock meridian quadrant, therefore it will turn it medially in a rotary fashion. Therefore, it becomes intortor. So this superior rectus will be represented by elevation, adduction, and intorsion. So superior rectus elevator, adductor, intortor. Same is depicted in this diagram. Superior rectus, three parameters are the elevation, adduction, intorsion. Inferior rectus, it starts from the ligament of Zinn, runs anteriorly outward, but below the globe. Where the superior rectus was above the globe. So it runs almost parallel to the superior rectus to get inserted into the outer anterior inferior quadrant. So it is going below this. So it will pull the anterior part downward. Therefore, it is a depressor and it will be an adductor and it will be an extortor because it is pulling the 6 o'clock meridian in a rotary fashion towards the nose. So 12 o'clock meridian will go outward. Therefore, it is an extortor. Superior oblique, starting from the anal of Zinn, runs anteriorly, comes backward, you already seen. You can see in the video, it is adducted and it is going down. So this is the action of the superior oblique. Superior oblique, origin from the sphenoid bone, runs outward, outward and outward below the globe to get inserted to the, sorry, it runs outward above the globe to get inserted to the posterior superior outer quadrant. So the superior oblique takes its origin from the sphenoid bone, runs anteriorly, then comes backward, having gone through the trochlea, runs above the globe, getting inserted in the posterior superior outer quadrant. So this is the superior oblique. So when it pulls here, this portion will be elevated, thereby depressing the cornea. So it will be a depressor. This portion will be turned towards the nose, therefore it will act as an intortor. Now again it will pull, the posterior part will be pulled towards the nose, the anterior part will go outward, therefore it becomes an abductor. So superior oblique, primary action is not depression, it is intorsion. Secondary action is depression. Tertiary action is abduction. So superior oblique will be abductor, the depressor, and intortor. We can remember the actions of superior oblique by the mnemonic solid. Superior oblique, lateral rotation, intorsion, depression. Inferior oblique. Primary action, extorsion. Secondary action will be elevation and tertiary will be abduction. So this is the inferior oblique. It is going below the globe. Origin at the floor of the orbit, hold below the globe, runs posteriorly and rounds outwards, getting inserted to the outer inferior posterior quadrant. Outer inferior posterior quadrant. So these are the picture of the various muscles. Superior oblique is like this. These are superior rectus. Here you have the inferior lateral rectus here, inferior rectus here, and medial rectus here. This is the right eye inferior view. This is the oblique that is come from medial part getting inserted the posterior inferior outer quadrant. This is posterior inferior outer quadrant. Because if you are looking from below, you are seeing the muscles very well. Inferior oblique, primary action, extorsion, secondary action, elevation, tertiary action, abduction. Now, the usual way of testing the extraocular muscles will be to test in an H-shaped fashion. What you are asked to do is just like an H. Horizontal movement is executed to the right gaze, then to the left gaze, then upward on the left side, downward on the left side. Again, upward on the right side, downward on the right side. So this is how it is moved. One movement is outward like this in one direction, then upward, then downward. Next will be in this direction, other side of the gaze, then downward and upward. So H-shaped manner it is being examined. There is a reason for that. Now, when we are moving the eyeball in the primary position, so elevators will act. Now, when you move the eyeball straight upward, both the superior rectus and inferior oblique of that eye will act. So right superior rectus will act, right inferior oblique will act. Both of them are elevators. Superior rectus is an adductor. So when you elevate like this in primary position, you look upward, you will find that the eyeballs move upward, superior rectus and inferior oblique acting together. Superior rectus will act as an adductor, inferior oblique will an abductor action. So adduction, abduction will be cancelling each other. For example, right eye. Right eye you are doing like this. The superior rectus will be an adductor, inferior oblique will be an abductor. So when you elevate like this, the adduction action of superior rectus and abductor action inferior oblique will be cancelled, and therefore it can straight away elevate the eyeball without any adduction or abduction. Similarly, superior rectus and inferior oblique are acting. Superior rectus is an indorter, inferior oblique is an extraorder. So they also cancel each other. So when you are actually elevating the eyeball in the primary position, going upward like this, superior rectus and inferior oblique will be acting. Superior rectus adductor action, inferior oblique abductor action. Superior rectus introctor action and inferior oblique extroctor action will be cancelled. So cancelling the opposite ones, what will be left will be elevation only. So when where we are straight away looking upward, there is no adduction or abduction of the individual muscles. One will cancel the other. Superior rectus adductor will be adduction action will be cancelled by inferior oblique abductor action. Indorter action of superior rectus will be cancelled by inferior oblique extrorder action. So this is how we are able to look upward straight or upward or downward straight. So in this position, we cannot test the superior rectus or inferior oblique separately. We cannot test superior rectus and inferior oblique individually when you make movement upward in the primary position. So when you are moving like this, both will be acting. So if you want to test the superior rectus, we have to cancel the other action. If you want to test the inferior oblique, you have to cancel the other action. Principle. Now what will you do? Separate out the actions of vertical elevators and depressors. Vertical elevators and depressors are superior rectus, inferior rectus, superior oblique, inferior oblique. That has to be separately tested. Test each one in isolation. Test the superior rectus, test the inferior oblique, test the inferior rectus, test the superior oblique separately. Elevations, depression should be tested for each rectus and each oblique muscle. Combined testing cannot work. How to separately test superior and inferior rectus? Now, we have already seen that initially I told you there is an axis of the globe which is looking straight. There is axis of the orbit which is going in a slanting manner, making an angle of 23 degrees with the axis of the eyeball. Now, what you have to do is bring the axis of the eyeball parallel to the axis of the muscle. Parallel to the axis of the muscle. So the eyeball is like this. And if you want to test the recti on the right side or the oblique on the right side, you should make the eyeball parallel to the muscle. For example, if you take the recti muscles, right rectus muscle will be or a superior or inferior will be going outward like this. So in the primary position, you cannot test superior rectus or inferior rectus individually. So in order to test the superior rectus, what you have to do is abduct the eyeball. When you abduct the eyeball, the superior rectus now becomes parallel to the axis of the eyeball. Normally, axis of the eyeball is straight. When you abduct it, now it becomes parallel to the superior rectus, also to inferior rectus. So when the eyeball axis become parallel to the rectus, superior and inferior, there will be maximum efficiency for the recti muscles to act as elevator or depressor. Once more, when you are normally, we are looking straight. When you want to look up, you are using both superior rectus and inferior rectus. Sorry, superior rectus and inferior oblique. When you are looking down, inferior rectus and superior oblique. So here, in order to test the superior rectus or the inferior rectus, what you should do is abduct the eyeball. When you abduct the eyeball, the axis of the eyeball becomes parallel to the axis of the muscle. Axis of the muscle is parallel to the axis of the orbit. So when it comes in the abducted position, the axis of the eyeball is in parallel with the axis of the superior rectus and inferior rectus. Only in this position, superior rectus and inferior rectus will act as elevator or depressor respectively. In another position, it will not act as prime elevator or depressor respectively. See, abduct the eyeball. Now it becomes parallel to the recti. When you turn the eyeball to the right side, right eye is abducted. Therefore, now it is parallel to the superior rectus and inferior rectus. This is the ideal position for testing the right superior rectus and right inferior rectus for elevation and depression. Only in the abducted position, you should test elevation, depression of the recti. This is a very, very important point. So, how do you test the recti? Bring the eyeball axis parallel to the axis of the recti. What do you do? Abduct the eyeball. Then, if you look upward, superior rectus will be acting. If you look downward, inferior rectus will be acting. If you look straight and go upward and downward, superior rectus will act, inferior oblique will act. Inferior rectus will act, superior oblique will act. Therefore, you cannot separately test individual muscles. So, abduct the eye and ask to look upward. To look at the right superior, for example, you look at my side. My right superior quadrant. My right eyeball is abducted, looking upward. This is the right superior quadrant. Therefore, the muscle that is permitting my right eyeball to look upward will be the right superior rectus. If I am looking downward, the muscle that is permitting me to look downward, the right inferior quadrant, will be right inferior rectus. That is very, very important. So in the abducted position, the recti come into action as prime elevator or depressor, depending upon whether it is superior or inferior rectus. Now, patient looks to the right eye globe is parallel to the recti. Only the recti will act, oblique will not act as elevator or depressor. Simultaneously, what happens to the left eye? So right eyeball, I am looking to the right side. That is right gaze. So right eye has acted as elevator, right rectus, superior rectus has acted as elevator, inferior rectus can act as depressor. Now simultaneously, left eye is adducted. So you cannot abduct the right eye without adducting the left eye. Now, when you are abducting the right eye, left eye gets adducted. Therefore, it becomes parallel to the oblique. So, in the left eye, only the oblique will act. So, when you are looking straight, looking upward, superior rectus, inferior oblique, inferior rectus, superior oblique will act. When you turn the eyeball to the right side, right gaze, you will find for the right eye, the globe has become parallel to the recti. For the left eye, the oblique has become parallel to the globe. Therefore, for the left eye, axis of the globe and axis of the oblique muscles are parallel when there is a right gaze. So, in this position, if you ask the patient to look upward, right eye will be elevated by the right superior rectus. And what is the elevator of the left eye? As far as oblique is concerned, it is the inferior oblique. So when you look at the right superior quadrant, the right superior rectus will elevate it. Left inferior oblique also will elevate, so that you are looking in the right superior quadrant. For example, my gaze, I am looking to the right side, right eye is abducted, left eye is adducted, right eye become parallel to the right eye. Therefore, elevation depression has been the property of right eye only. For the left eye, when the eyeball is adducted, it has become parallel to the oblique. Therefore, the function of oblique will be elevation depression. Where so when you are looking at the upper part, right superior quadrant, so elevation has been done by inferior oblique. So when you are looking at the right superior quadrant, right superior rectus and left inferior oblique. My right gaze is, I am maintaining a right gaze. I am looking downward. The muscle that is acting is right inferior rectus and left superior oblique. Because the oblique is acting now for the left eye. So this is how we have to interpret the muscle action. Therefore, adducting the eye, isolate the elevating action of abducting the eye, isolate the elevating action of superior right eye. Isolate the depressing action of inferior rectus. Attacking the eye, isolate the elevating action of inferior oblique and depressing action of superior oblique. So when the patient is asked to look the right side, then look upward. Patient is looking to the right superior quadrant. When the patient is looking at the superior quadrant, right superior quadrant, the muscles that are acting to make the patient to look at my right superior quadrant will be right superior rectus and left inferior oblique. When I am looking in my right inferior quadrant, the muscles that are acting will be right inferior rectus and left superior oblique. When I am turning the gaze to the left side and looking upward, I will be looking at the left superior quadrant. The muscle that acts to bring both eyeballs to this quadrant will be for the left eyeball. Now it is parallel to the recti, therefore it is left superior rectus. At the same time, I have adducted the right eyeball. Now it becomes parallel to the oblique. So left superior rectus and right inferior oblique. So if you are looking at the left superior quadrant, the left superior rectus will act, the right inferior oblique will act. When I am looking downward to look at the left inferior quadrant, the muscles that are working or the action, the muscles that bring the patient, my eyeball to the left inferior quadrant will be the left inferior rectus and right superior oblique. So right superior quadrant, right superior rectus, left inferior. These are the yoke muscles. So when you are looking at the right superior quadrant, right superior rectus, left inferior. Right inferior quadrant, right inferior rectus, left superior. Left superior quadrant, left superior rectus, right inferior. When looking at the left inferior quadrant, it is left inferior rectus, right superior. Now this is termed as Maddox mnemonic. So if you are looking at any quadrant, right superior quadrant or right superior quadrant, corresponding rectus will be active. What is the quadrant? Here it is, patient is looking at you, right superior quadrant, corresponding rectus, right superior rectus, and left inferior oblique. So right superior quadrant, The muscles that are acting will be corresponding rectors. Right, superior, quadrant rectors. So corresponding rectors of the right superior rectus, and the most cross-named muscle. Put instead of right, put left. Instead of superior, put inferior. Instead of rectus, put oblique. So when somebody is looking at the right superior quadrant, my own right superior quadrant, corresponding rectus will be right superior rectus and left inferior oblique. When I am looking in the left superior quadrant, corresponding rectus will be left superior rectus and most cross-named muscle, that is the right inferior oblique. When I am looking at the right inferior quadrant, corresponding rectus and most cross-named muscle, left superior oblique. When I am looking at left inferior quadrant, corresponding rectus, left inferior rectus and right superior oblique. So this is the same thing summarized in another manner. There are two rules of diplopia that we should know. Images should be maximally separated when the patient looks in the direction of action of muscle. So you got two images. It is separated. When you look in the direction of action of muscle, there will be diplopia. What you get here will be called binocular diplopia. So if you are looking at the right superior quadrant, the muscles that are working there will be right superior and left inferior oblique. Find out in which quadrant you are getting maximum diplopia. What is meant by maximum diplopia? Maximum separation of images. So when the vertical muscles are acting, the eyeballs, the images will be separated upward and downward. Whereas lateral rectus and medial rectus, they will be horizontally separated. Here you find when you are looking at the elevation, depression actions of the muscles, you will find it is vertically separated. In which quadrant you find out is the maximum separation. In one quadrant it is like this, another quadrant is like this. So maximum separation images occur in the quadrant where both the muscle is acting. So if we find maximum separation of images occur in the right superior quadrant, we have already seen the two yaw muscles that are acting to bring the eyeballs to look into the right superior quadrant will be right superior rectus and left inferior oblique. So if there is a maximum diplopia in right superior quadrant, muscles at fault can be right superior rectus or left inferior oblique. If there is maximum diplopia looking right lower quadrant, muscles at fault will be either right inferior rectus or left superior oblique. If it happens that maximally separated is in the left inferior quadrant, only two muscles are at fault. One of them, left inferior rectus, right superior oblique. If maximum diplopia as defined by maximum separation of the images occur the left superior quadrant, it is left superior rectus and right inferior. Now having defined that, either the diplopia here only two muscles, here also two muscles. So all the quadrant we can narrow down to two muscles, one of them is at fault. Now, if there are three images, outermost image always belongs to the paralyzed side. Paralyzed side. If there is a right superior, so left superior to the right inferior oblique, maximally separated in this quadrant, it is either left superior rectus or right inferior oblique. Ask the patient to close one of the eyes. When the patient closes one of the eyes, identify which image will disappear. There are two images. My left finger is outside, right finger is inside. So maximum separation images occur in this left quadrant, left superior quadrant. I close the left eye, right eye. Then this disappears. That means the paralyzed eye is coming from the right side. So that means it must be right inferior oblique. That is the one that elevates. If I close the left eye and outer one disappears, it is the left superior rectus. So this is how we resolve the actions of extraocular muscle, looking for binocular diplopia and finding out in which direction the images are maximally separated, and closing one eye, find out by closing which eye the outer image disappears. By that you can say whether it's a superior rectal, inferior rectal, superior oblique, or inferior oblique. This is how it is being done. The practical way of analyzing the movement of the eyeballs by each muscle. So the only thing we should learn is that we should not, even though there are actions, primary, secondary, tertiary actions, these elevators and depressors should be tested by separating their elevation depression action away from the opposite muscle. Otherwise, we will not be able to get any idea at all. And this mnemonic will be useful only when there is a single muscle paralyzed. Suppose you got a superior rectus paralysis, inferior rectus paralysis, inferior oblique, third nerve, all the muscles are paralyzed, this will not be useful. So this is in general the way you should proceed. And I also try to explain why you are testing using a edge shape, the wide edge you are using in order to test the muscles. Thank you so much.